Welcome to Endoscopy Talks. I'm Dr. Dave Tweed from Colorado State University, and I want to thank you all for joining us on behalf of Colorado State University's new Translational Medicine Institute. Today, we are joined by a good friend of mine, Dr. Elise Robertson. She's a noted feline specialist who runs a feline medicine and endoscopy referral service in the UK, as well as throughout many practices within Asia. She is a graduate of the Royal Veterinary College in the University of London and is an ABVP feline specialist. In addition to her clinical work, she also lectures worldwide on feline medicine, endoscopy, and endourology. She will be teaching a feline-only endoscopy week course at the Translational Medicine Institute this coming July. This is something that if you're a feline person, you don't want to miss. Her webinar today will be on the versatility of a rigid endoscope that can be used to evaluate the respiratory, the auditory, and the urogenital system. And with that, it's my great pleasure to introduce Dr. Elise Robertson.
Thank you very much, Dave. Let's see here. Good. Can you see that screen okay?
Yes.
Fantastic. So thank you very much for that kind introduction. I'm lecturing on two of my most favorite subjects, which is endoscopy in cats. So I just want to thank Colorado State University and Karl Storz for inviting me to be part of this amazing lineup of speakers throughout the past few months. So thank you very much. Let's see here. So first of all, I want to pay a thank you to Colorado State University and Karl Storz for inviting me to speak, but I also want to disclose a few things. So I have, throughout this lecture, I do refer to a lot of Karl Storz equipment. I'm not paid to do this. It is my own preference in feline endoscopy, so we'll go through that a little bit later. And I also teach at Colorado State University. I also run my own particular business called Feline Vet Limited, so I am a company director and a shareholder, but I do not receive any funds for research, clinical trials, or drug studies. So the objectives in the plan for this evening, I wanted to really give you a little flavor of what the rigid endoscope can provide you as a feline practitioner. It does provide a basic, I want to provide a basic overview of feline-specific rigid endoscopy and how it can be integrated into perhaps most medical investigations in feline practice. This presentation is intended to engage both general practitioners and probably canine-centric referral clinicians, so those clinicians that do a lot of endoscopy, but maybe not so much in cats. Hopefully you guys can also benefit from this presentation. Saying that, this is going to be a really brief overview of what you can potentially achieve with the rigid endoscope, but I do highly advise enrolling on feline-specific endoscopy course. I think it's quite important when we're working in small spaces to understand particularly haptic feedback in these small working spaces. This is quite a vital skill to learn. And unfortunately, YouTube education is not appropriate for that. So I do encourage you to register onto a course. We're going to explore the anatomy of the multi-purpose rigid endoscope and the imaging chain, and basic principles regarding viewing angles, and then some procedures that can be achieved with the mini MPR. I thought I would give you some access to some feline-specific endoscopy references. So back in 2013 and 2014, there was a special edition of Journal Feline Medicine and Surgery dedicated just to feline endoscopy. It is a little bit aged, as I said, 2013 and 14. However, a lot of the techniques haven't really changed over the years, so this is quite a good resource for you that's really geared for the general practitioner. In addition, we are coming out with the second edition of the BSABA Manual of Canine and Feline Endoscopy and Endosurgery that hopefully should be coming out in the next month or two. So I am a peripatetic vet, which means that I go around to a variety of different veterinary surgeries all over the southeast of England. So I cover about 150 veterinary practices, and I see a lot of their cases outside of the referral institution. And then I also practice out of Asia, so Singapore, Kuala Lumpur, Bangkok, and some various places around in Southeast Asia. So on an annual basis, I see probably about 400 to 500 cases a year. Of those cases, I would say about 55% of them are cases that require rigid endoscopy. And a majority of that, probably about 40% of that, is upper respiratory endoscopy. Then we've got probably otoendoscopy, really depending on what part of the world I'm in. So in the UK and Europe, probably not all that common. But when I'm working in Asia, it is quite a large caseload of mine. So I say anywhere between 5 to 10% of cases. Lower respiratory, we talked about tracheoscopy. I'd say pretty small volume of cases, and urethrocystoscopy, again, probably not so much of my caseload. So overall, we're probably going to put a lot of focus on upper respiratory and otoendoscopy, just because I find that ENT tends to be a really big benefit when we're using the mini MPR. So typically when we're practicing medicine, we will go through this roadmap. This is a roadmap that's probably been banged in our heads ever since vet school. We take a patient's signalement, the history, go through a full clinical examination, and then we typically will run our gold standard diagnostics. So oftentimes that's a minimum database, bloods, urine, maybe some radiography. And then we get to this diagnostic roadblock where oftentimes we're stuck with repeating tests, repeating symptomatic treatment. So for instance, a chronic rhinosinusitis, we might be repeating antibiotics, maybe some antivirals, or we may end up referring. So I refer to this as the diagnostic roadblock, which is commonly a big problem out in general practice. And this is where I want to introduce endoscopy, because this is the thing that can probably get you beyond this diagnostic roadblock. And endoscopy offers not only diagnostic information and a visual sample, but also offers therapeutic intervention. So I am very much convinced that many, if not most, medicine cases, feline medicine cases, are an endoscopy case in one way or another. In feline practice and in veterinary practice, we really talk about evidence-based medicine triads. So we're always talking about taking the best evidence and using that evidence in making clinical decisions. And that's very good if you're looking at journals, but oftentimes a lot of the journals that are coming out in the literature aren't necessarily applicable to everyday practice. So I'm trying to reframe practitioners' point of view, instead of really focusing on the evidence-based medicine pyramid, to think about maybe an evidence-based practice triad where we consider the best external evidence in the literature, but we also need to incorporate our individual clinical expertise, because that offers a lot of value. A lot of stuff that enters into journals may not necessarily represent what we're seeing down on the ground. And then also we need to consider client values, expectations, and the patient compliance. And I think all three of these form the evidence-based practice triad. And endoscopy can certainly help out in a variety of different cases when we're considering this. So for instance, a lot of endoscopy in feline practice isn't necessarily published in the literature, but that doesn't necessarily mean that it's not useful. So I want to start off with what's a universal MPR, or multi-purpose rigid endoscope. The multi-purpose rigid endoscope is a stainless steel tube, and it's got a series of glass rods inside the tube. And this is quite a fragile system. And the glass rods help illuminate and magnify an image. So compared to a disc system where you have a series of glass discs, the rod system tends to be quite a useful piece of equipment. And oftentimes we'll have a variety of different sheaths to protect that endoscope. So whenever you're using a rigid endoscope, you must always use a sheath. And there's a variety of different sheaths available. So you can have a cystoscopy sheath, an arthroscopy sheath, but really the basic principle of a multi-purpose rigid endoscope is using this tube inside a cavity. So as I say, when we're using this in whatever cavity, you have to have a sheath, and it can be an operating sheath. So that's the middle picture. So that doesn't have a biopsy channel to it, and it only has one port for irrigation. That can be useful because basically you're reducing the cross-sectional diameter, but it does have its limitations. So you'll see this sheath out and about as well. So again, when we're talking about the endoscope, they come in a variety of different sizes, but also viewing angles. So if you look at the image on the left, this is a series of 3 different rigid endoscopes, and they vary according to the cross-sectional diameter. So the top one is a laparoscope. That's a 5mm diameter. We typically will use that for laparoscopy or thoracoscopy. But it's probably not too useful when we are talking about rhinoscopy in dogs. It's pretty big, so that one we don't tend to use all that often unless you're doing, as I say, laparoscopy or thoracoscopy. The middle one is a 2.7mm, so that's the one that we would typically call the universal MPR. So that traditionally has been used in virtually everything. You can use that both in dogs, and technically, yes, you can use that in cats, but it tends to be quite a tight fit once you get the sheath over the top of that. And then the bottom one is a 1.9mm, and that's an integrated sheath. And that one is the one that we typically will use for cats. So that one I will use probably in most cats and also small dogs. The middle image is showing you the viewing angle. So typically in veterinary practice, we'll either use a 0° or a 30° oblique angle telescope. The 0° is basically allowing you to see the field of view, but only directly what's in front of you. So that can be useful if you're first starting out, for instance, with laparoscopy. It gives you a true image of what's directly in front of you, so it's quite intuitive for the beginner. But when you're working in tighter spaces, it's got some significant limitations. Because in order to view, for instance, to the top or the bottom, left or right of an image, you would actually have to move your whole entire arm left, right, up and down, and that can cause some significant soft tissue damage. So a way of combating that is that we will use an angle telescope. So we will typically use a 30° angle telescope, and that's very useful in many patients. You also find out in the market that there's other more acute angled telescopes, but that's more for human medicine. So by convention, we'll typically use either a 0 or a 30°. With any type of endoscopy system, we do need to have an imaging chain. So whether you're doing gastrointestinal endoscopy or rigid endoscopy, so flexible or rigid endoscopy, you need to have a good light source. We typically will use a xenon light source in practice. Halogens probably not strong enough in many systems, so I would advise that if that's what you've got in practice, to see about trading that in for a better quality light source. We will typically also use a camera control unit, and that's attached to a CCD chip, which is in the camera head. And that's a way of taking an image from the field of view and digitally turning that into an image that's projected onto a monitor. Traditionally, we used to look through the oculus or the eyepiece just with your naked eye, but with a lot of the procedures these days, that would be considered pretty unhygienic. And I know with a lot of cases that I do see, I wouldn't want my face near half the snotty cats that I see. So I would advise getting a digital system that you see here. And then you also need to have a light guide cable which connects from the light source to the light guide post of the endoscope. This image over on the right, this is a video, and so basically your endoscope will typically be in a protective sheath, and what you want to do is wipe off the oculus of any fingerprints and also from the camera head, because that can, if you have a fingerprint, that can pretty much blur your image. Then what you want to do is take the locking piece on the camera head and make sure that's securely attached to the oculus of the endoscope, and then attach the light guide cable to the base of the endoscope. Then whichever sheath you decide to use, depending on the procedure, you just slide that over the top of the endoscope and lock it into place. And then what you want to do is take the valves, make sure you turn them off. So you've got an ingress and an egress port, and also on your biopsy channel. In this case, we're probably going to be doing some either cystoscopy or rhinoscopy. So typically you would attach continuous irrigation to one side. It's to a fluid bag and an IV fluid set, and you can attach that to one side. And then you can either attach suction to the other port. You can leave it open, or what I typically will do is attach a 10 or 20 mil syringe to that other port to use for additional irrigation. So I'll just show this one more time. So the light guide post goes, or the light guide cable goes onto the post. The sheath over the top, make sure that's locked into place. And then your continuous irrigation can go onto one port, that's typically the ingress port. And then the egress port, which is the other port, you can either attach suction, or as I say, a 10 or 20 mil syringe, which can act as additional jetted irrigation. If you've got a really snotty cat, that's quite good to blow away some quite more residual snot that's not lavaging away with gravity-fed irrigation. So that's quite a bit to take on so far, so I felt that this was a natural point to maybe stop and see if there are any questions so far before moving on.
I guess we have one or two questions. Are rigid endoscopes used more commonly than flexible in cats? And for what purpose would I need a flexible instead of a multi-purpose rigid scope?
Yeah, that's a very good question. So flexible endoscopes tend to be used for more tortuous pathways. So for instance, we've used that maybe for tracheal bronchoscopy, where you need that flexibility to get into more tortuous pathways. You'd use a flexible endoscope for retroflex nasopharyngoscopy, so you need to have that nice bending over the top of the soft palate. You would also use the flexible endoscope for upper and lower gastrointestinal endoscopy, where you need to go through little bends and curves. So that's typically what you would use that for. The rigid, I would say, is more for getting access into the nose, the ear, the trachea, and also the urogenital system. So as I said in the beginning, I would say about 55% of my caseload is rigid endoscopy, and then the rest is flexible. So I would say I get a lot of use out of the rigid endoscope.
Okay, we have one more question, and I think you're probably going to answer that, but do you use a sheath with the 1.9 millimeter scope when performing rhinoscopy in cats? And if yes, what type of sheath?
Yeah, absolutely. With any type of endoscope, we will use a protective sheath. That's absolutely vital. Some of the older text you might, or even some literature on the internet, you might see that an endoscope is being used naked, and that's a good way of potentially flushing 3,000 to 5,000 pounds down the toilet, because any fulcrum forces against that longitudinal axis of the endoscope will destroy the glass. So always use a sheath. With the 1.9, to answer your question, we'll go through that a little bit later, but you can get integrated sheaths, or you can get ones that are separate, smaller sheaths. So we'll go through that a little bit later.
Okay, that's it for now.
Good. To go through a little bit more about the concepts of rigid endoscopy, we're going to talk about the 0-degree endoscope first. You can get this in any diameter size, but it's more commonly in the 5 millimeter, 10 millimeter laparoscopes, and when you're also doing thoracoscopy, sorry. And as I say, the lumen, when you're looking at the monitor, the lumen will typically be in the center of the screen. So when you turn the light guide post along its longitudinal axis, and you'll basically see the field of view directly in front of you, no matter what position your endoscope is in. So provided you keep it straight ahead of you and you move your light guide cable around, your field of view will be right in the middle. So this is an example. So when a basic principle, when we are using an endoscope, I'll always keep the camera head with my thumb on the control buttons to make sure that they're always pointed up. If you've got your control buttons pointed to the side or upside down, what happens is your image is going to be quite distorted as far as position. So it's always important to keep your camera buttons and your controls pointed up. So I always have my thumb on there just to make sure that that's always in the correct position. And as you can see, when I rotate the light guide cable around, the Joker's head, this is just for illustration, it pretty much is still in the center of the image. So as you can appreciate, it's quite intuitive. But when you're working in a tighter space, that's going to be very limiting because you're not going to be able to see peripherally what's going on. And in order to see any pathology in a peripheral, you'll have to actually move your endoscope left, right, up, and down. And what happens by doing so is you cause significant soft tissue damage. That's particularly true when you're in the nose or even in the urogenital system. You potentially could tear the tissues. So it's quite dangerous. So when we're using a 30-degree oblique telescope, typically when you're looking at the monitor, the lumen will either be in the periphery. So it will either be on the bottom, the top, or the sides, really depending on the position of where your light guide cable is. So again, if you rotate the light guide cable around, that will give you the peripheral image. And as you can see with the Joker, as you're moving the light guide cable around, see how it definitely expands your field of view just by having that bevel bend. And this is absolutely vital in feline endoscopy because everything is so miniaturized and a lot more tricky compared to medium-sized dogs. So this is why we opt for a smaller diameter and opt for a 30-degree oblique. So the MPR typically, if you see that in literature, that's typically referring to the 2.7 millimeter 30-degree oblique. When you see mini MPR, that's just a miniaturized version of a multipurpose rigid endoscope. So a mini MPR is a 1.9 30-degree oblique. And the one that I typically will use is, Karl Storz has got an excellent scope that I typically use for virtually everything. This is my workhorse all day, every day. I will use this. I probably use it approximately 2 to 3 times a day, 5 times a week. So 5 days a week. So this is the one that I would definitely recommend. The length is absolutely adequate. It's about, I think it's 18 centimeters long. And so you can get into the nasopharynx quite easily. And also the irrigation I find is really good. So you can get similar sized ones where they're detachable, where it's the detachable sheath. And the irrigation is still quite good in that. So you can get that, I think, with the arthroscopes. But I find this one is a little bit more forgiving in the cat. It's got nice smooth edges and everything. So the difference with the irrigation, and this is the vital thing, is that with anything that we're using the multi-rigid endoscope, we typically will use irrigation, and this is particularly true in rhinoscopy. The irrigation is vital in cat noses especially. So if you try using a 2.7 millimeter 30-degree oblique with a sheath, that's absolutely fine. You'll read in the text that it's possible to do rhinoscopy with these, but unfortunately the cross-sectional diameter is greatly enhanced once you put a sheath over the top. To reduce that, I don't know if you remember me saying in the beginning, we can use an operating sheath which reduces that cross-sectional diameter, but in doing so, the irrigation is reduced because the fluid has to go in between the sheath and the endoscope itself. So as you can see, on full blast, it will literally just drip out. And when we're dealing with snotty cats, the purulent material is oftentimes chronic, really thick, and it just won't dislodge. So with the mini MPR, as you can see, it's all integrated, and the irrigation goes over the top of the endoscope itself rather than around it. And so it gives a really nice forceful jet. That coupled with, so that's gravity fed irrigation. So that coupled with a 10 or 20 mil syringe on the egress port will give that extra additional jet of flushing if you need to remove any debris. So this is a really nice endoscope to use. With these endoscopes, you can get accessory equipment, so semi-flexible biopsy forceps. You can also get grasping forceps. The limitation with the mini MPR is the biopsy sample size, because as you can imagine, everything's miniaturized, so your biopsies are going to be minuscule and oftentimes not very diagnostic. Most of the cats that I see will need, will need to have debriding biopsies. They tend to be really chronic cases where either the turbinate tissue is completely destroyed, and it tends to be a focus or an itis of infection. So oftentimes it ends up being a turbinectomy by the time I get in there, or we tend to do tumor debridements. So instead of using the integrated biopsy channel, I'll typically use the biopsy forceps over on the right-hand side, which is 3 millimeter rigid cupped biopsy forceps. And those give me some really nice representative samples. The reason why I would suggest you going on to a wet lab course is because understanding how these work it's not very intuitive, and oftentimes they're blind. So you kind of need to have that haptic feedback to know exactly if you're in the dorsal, middle, or ventral meatus to get your biopsy samples. So oftentimes I'll do a full examination, and then I know exactly where to take my biopsies depending on the location. So again, that can be taught in a wet lab. Again, the mini MPR, the channel is quite accommodating for diode laser filaments. So I know David Sobel's done a great lecture on laser therapy. So this is very good for debriding tumors, but also breaking down nasopharyngeal stenoses, which I'll show a little bit later on. So the channel is quite useful for some interventional procedures. So again, a natural spot to probably ask some questions before then moving on to all the various procedures that we can achieve, because again, I know that we've been through quite a bit so far.
Yeah, there's only one question, and it says and that has to do with biopsy samples, and because they're very small, is there any special thing that you do, or do you only do cytology with those samples?
Yeah, that's a very good question. Oftentimes, by the time they come to me, they're usually either tumors, so lymphoma or adenocarcinomas. So when you put the endoscope in, you'll see the tumor right. They're oftentimes right in the middle meatus and also the ventral meatus. So you know where your tumor is. So then you can go in, pre-measure from the medial canthus to the tip of the nose, and then you put your rigid 3 millimeter cupped biopsy forceps in, and then you can take your debulking samples. With the chronic rhinosinusitis, where basically the tissue doesn't really bleed all that much, you can tell that that's very dead tissue, and with endoscopy you can tell because it's the tissue is sloughing away. When you take your biopsy, literally it will tear away with very little bleeding as well. And I will take that biopsy, because it ends up being a turbinectomy. I'll take a piece of that and I'll put that piece of biopsy straight into culture medium, and I'll take another piece of that biopsy and I'll put it straight into histopathology. So yeah, the biopsies I tend to take are more what we would consider blind. Hopefully the biopsy channel will start to, I'm hoping that as things progress with developing new endoscopes, that perhaps the biopsy channel will increase without compromising the optics, because obviously you have such a small space that if you increase the size of one channel, then obviously you are compromising on the benefit of the optics. So hopefully in the future we'll have a channel that's big enough to be able to do guided without reducing the image quality.
Okay, that's it for now.
Good. So I'm going to start off with respiratory endoscopy. As I said, this is the one that I tend to do pretty much all day, every day throughout the week. This is my bread and butter, and I guarantee that most feline practitioners will have at least 3 to 5 cases a week if they're looking for them that could benefit from rigid endoscopy. So this is a case that I saw last week, and this is typically how they present. To me, they've been on a variety of different antibiotics, partially responsive, and maybe some antivirals, maybe partially responsive to that. But more times than not, they'll come back with exactly the same presentation. And most practitioners will get them in for a general anesthetic, give them a nasal flush to find that probably about 2-3 weeks later, they represent just like this. And it's because nasal flushing with 10-20 ml syringes is not enough to completely evacuate this purulent material from in between the turbinate tissue. So there are a variety of reasons why cat will present like this. So it's not only cat flu, it can be due to tumors, it can be nasopharyngeal stenosis, it can be fungal, it can be a variety of things. And this is where endoscopy will help you rule those things out, but in addition, give you some therapeutic benefit. So these are the images from the inside the nose. This is an atrophic rhinitis. This is quite a young Bengal. I think he was only about 10 months old. And as you can see from the top picture in the middle, basically this is an atrophic rhinitis. So all the turbinate tissue is completely retracted back, and this is just a virtual space now. So this gives me an indication of what this is, but also it helps me communicate to the owner that really this is pretty end stage at a relatively young age, and it helps manage the owner's expectations moving forward that this is going to be an ongoing problem. But they've got visual evidence of this, so they almost appreciate and become more compliant because they've got this visual evidence. In the middle image on the lower left-hand side, this is the other side, or the other nostril, and the turbinate almost has this clubbing effect. So we call this mucosal clubbing. You tend to get mucosal clubbing with chronic rhinitis, and oftentimes this is feline herpes virus-induced rhinitis, and then it's no longer really the virus itself, but it's the immune system. So that's attacking itself whilst trying to attack the so-called virus. So this is now an immune-mediated driven process. And in fact, that's what contributes to erosion and then secondary bacterial infection. So when I go in to take biopsies, I'll take debriding biopsies and I'll submit that for culture and sensitivity, because oftentimes the culture will come back as a Pseudomonas osteomyelitis. So you get your sensitivity profile and you're able to get this animal onto appropriate treatment, which oftentimes is a triple combination treatment of anti-inflammatory steroid, famciclovir, and then the antibiotic that it's sensitive to. So it's a 3-pronged approach in addressing these problems. But it's the continuous irrigation, remove that material, that really I think is beneficial to this cat. This cat's only seen me, he's now I think about 5 years old, and he's only seen me twice just to get another re-evacuation of that material, but he responds really well to that triple combination treatment, and he has a good period of about 1.5 years without needing any treatment at all. So I find that in general, that's quite successful considering the visual evidence of complete destruction we've got. The image over on the right is an example of what a eustachian tube looks like coming in from the rostral direction. So you're able to get the endoscope not only into the dorsal and the middle meatus, but also into the ventral meatus and into the nasopharynx. And it's quite good to be able to take a look at the eustachian tubes to rule out any evidence of polypoid material. But also you can take a look at the adenoid tonsil, which is up on the top of the nasopharynx, just to look for any evidence of swelling. So like with lymphoma, you find that adenoid tonsil is really it almost looks like a cloud. It's quite polypoid, and that gives you an evidence that it may very well be, if this is an middle-aged to older cat, that there very well could be nasal lymphoma that's contributing to the chronic signs. Foreign bodies, this is another one that I typically will see, and these are examples of retroflexed, so taking a flexible endoscope, going up over the soft palate. The vets didn't find anything, and these are the ones that have been referred to me for ongoing rhinitis, and the foreign bodies were discovered going up the nose. So just because you can't see it retroflexed does not exclude a foreign body. You must always go up the nose. So the one on the left-hand side, this was pampas grass, and there were 7 grass blades that were removed out of this cat's nose, where retroflex there was nothing seen behind the soft palate. So that gives you enough evidence that a rigid endoscope is extremely valuable in these cases. This next case over on the right-hand side, this is a 16-year-old cat belonging to a nurse in one of the clinics that I go to, and she just said that her cat just had smelly breath. Nothing else, no sneezing. Went back with a flexible endoscope over the soft palate, just saw some purulent material, but no foreign body. Went up the nose, and this is what we ended up pulling out. So again, just because you don't see it, retroflex does not exclude a foreign body in the nose. Fungal granulomas. So aspergillosis is a massive one. I see a lot of these cases in the UK, but also in Asia. And I think the reason why it's not necessarily the incidence of disease in these geographical locations is increased. I think it's probably endemic. It's just that we're not finding it because many people aren't doing endoscopy in cats. So this is particularly important in your brachycephalic breeds. We're finding that aspergillosis is very common in your British Shorthairs, your Selkirk Rexes, some of your Devon Rexes, your Cornish Rexes. So some of these cats, we don't know why, but they seem to be more predisposed to aspergillosis. They do tend to be immunocompetent, so they're feline AIDS and leukemia negative. But again, these are cases that have presented with chronic rhinitis that don't resolve with antibiotics or only partially responsive. And these cases have been referred to me because they were ongoing chronic rhinitises. So again, fungal granulomas, a very common thing to see. Oftentimes, continuous irrigation, debridement is absolutely necessary, so you have to remove all the plaques. And I don't find that these plaques are invasive per se. I think they just sit on top of the mucosa. But unless you remove these, doing fancy treatments like posaconazole, systemic posaconazole, or intranasal clotrimazole is going to be of little use unless you remove these. And it's the continuous irrigation and the debridement that really help improve these cases. And in fact, there's a couple of cases where I've not needed to reach for either systemic or topical intranasal treatments. Just rhinoscopy alone and removing those fungal plaques was enough to resolve those cases. So, and that seems to be a similar finding in human medicine as well. This is another case. This is a case that was in North London, again, belonging to a nurse. I tend to collect nurse cases. But this cat had nasal sinus turfining and all sorts of different procedures, but they didn't. This practice didn't have a rigid endoscope. Went off for referral. They didn't have a rigid endoscope either, or they didn't do much in cats. So they just did a variety of different intranasal treatments, and understandably, it didn't last for very long because the fungal plaques hadn't been removed. So this cat, I did a continuous irrigation, removed all the fungal plaques, and then did a clotrimazole treatment, and the cat is still asymptomatic. So this cat was symptomatic for, I think, about 2 to 3 years, and this was the first treatment, and we thankfully got it resolved. I'm quite surprised because anytime you're dealing with a nurse or a staff member's animal, you know that they're going to be complicated, so I've been very lucky. This QR code is a publication that myself, Alice Tamburini, and Vanessa Bars had published on a rather complicated case of aspergillosis and a British Shorthair. Again, this cat had some destruction of the cribriform plate shown on CT imaging. So the owner opted to do systemic posaconazole with rhinoscopic debridement, and he's still asymptomatic, so that's quite a good outcome as well. But it did take some, I think, a couple debridements to get him resolved. This cat here is a 19-year-old domestic short, male neuter domestic short hair. The owner had contacted me on the internet, really frustrated that her cat was continuously snotty and getting worse, and she was concerned about a tumor. And she actually did her internet research and found that she wanted to find someone that did rhinoscopy in cats. So this cat, this is typical Sturter. We're not strangling the cat, by the way. But this is a classic, and again, was considered a cat flu, was put on various antibiotics, and it was partially responsive, but he was progressively getting worse. So in these cases, we can use them for not only diagnosing a tumor, but also tumor debridement. And that can either be done via a laser filament, or most of the time these cases, you can debride them using the 3mm cupped biopsy forceps. So this is his tumor, and this is nearing the nasopharynx. And as you can see, that this is a massive obstructive lesion that's not only obstructing the ventral meatus, but also partially the middle meatus. But I wanted to show that video just because you could, unfortunately, I don't think you can see it, the clarity on Zoom, but you can actually see that the endoscope magnifies everything so beautifully that you can see the individual red blood cells coursing through this vessel. And this vessel looks massive, but to be honest with you, it's probably about the quarter of the size of your pinky nail, so it's pretty small. But I was able to debride that and reestablish patency to the nasopharynx, and this cat did very well. So that was the tumor that we got out. And this is an email from the owner. Casper did really well. He's eating loads and looks well and happy again. And he continued on for another 2 years. He only needed 2 more debridements. It ended up being an adenocarcinoma. She didn't want to go down the radiotherapy route, so she opted to just admit him for debridement. And the quality of life that was achieved was pretty astounding. So the far picture on the right was my Christmas card of him wandering around in the garden again. So unfortunately, he passed away, I think it was last year, due to cardiomyopathy and a blood clot, so it had nothing to do with his nasal tumor. Nasopharyngeal stenosis is another really common problem. So typically, we traditionally had taken some vascular forceps, which is over on the right-hand side. This is an image given to me by Vanessa Bars from University of Sydney. And we would retroflex, take curved vascular forceps, put it through the stenosis and stretch that open. That's what we used to do. Nowadays, there are a variety of different ways of approaching it. Myself and colleague Philip Lermet, we've been basically taking a laser filament and using the multi-rigid mini endoscope and going up the nose, taking the laser and making 3 cuts along the stenosis. And then what you can do is take a balloon and stretch that open. And then after doing a serial stretching, you can take the laser and burn off the little bleeders, because we both suspect that perhaps the restenoses of these is perhaps due to the fact that the blood vessels, once you stretch that and there's bleeding, that they bring in inflammatory mediators that almost encourage probably restenosis. So we've had some really good results with this. Unfortunately, it's not published. I wish I had 26 hours in a day, but this is anecdotal evidence. But if you, so basically we'll burn off the little bleeders, and then what we'll do is take an endoscopic needle through that channel and inject triamcinolone in 4 quadrants around the stenosis. And as I say, these cats do really well. So this is just stretching that out. Typically you would use probably an esophageal balloon, but you can use a Foley. The unfortunate side effect of a Foley is that it will slip back and forth between the stenosis just because it's a round balloon. But as you can see, we got a great opening there. You can see the ET tube in the larynx. And then what we'll do is we'll take the laser and burn off the little bleeders. And then after that, you can replace the laser filament with a endoscopic needle, and then you can use that and inject steroid into 4 different quadrants to help reduce the inflammation there. So not only has this endoscope allowed us to diagnose the stenosis, but it's also allowed us an option for providing an intervention. This is a case that I saw in Singapore. Again, this in practice, we don't sometimes, depending on where in the world you're working in, you don't have the luxury of having a multi-million-pound fluoroscopy setup. So typically we would do this under fluoroscopic guidance. But if you don't have that, you can use, again, your mini NPR. And what I tend to do is the nasopharyngeal stenosis in the cat is a lot more, it's a lot easier to stretch and dilate and tear compared to that of a dog. With a dog, the waist of the stenosis is much more resistant to stretching, and oftentimes they regrow. They're an absolute pain. But in a cat, they tear pretty easily. And what I tend to do is I take a series of balloon sizes, and I'll put it through the stenosis, and with a pressure gauge, I'll blow it up and then do serial stretching with different sizes of balloons. So this is one particular balloon. And as you can see, it's not really stretching it all that much. So now I can go in with a different size balloon and stretch that even more and more. So I'm visually watching that until I get an adequate aperture size. And again, after you stretch those open, if you don't have a laser, you can do it this way. Then you can put, again, triamcinolone in your 4 quadrants to help reduce any inflammation. We can do laryngoscopy and tracheoscopy. So the image over on the left, the video I'm going to show you, is the normal larynx. And then the image in the middle and the right, so the right-hand side, that's from this cat in the middle. This cat presented to me just for dysphonia, so a change in voice quite acutely, but otherwise she was pretty normal, eating all right and just adapting quite well. But owner was just quite concerned that the voice seemed a little bit raspy. So this is what a normal larynx should look like in a cat. And the clarity is much nicer compared to a bronchoscope, for instance, because with a bronchoscope, you've got fiber optic bundles and you tend to get more of a pixelated view the smaller the diameter of the endoscope. So this is the benefit of using a rigid endoscope, is the rod system gives you a really nice clarity. So it is pretty amazing that this cat was surviving. Unfortunately, when I diagnosed this, that's pretty end stage, and the owner didn't want to proceed with laser debulking or anything. So unfortunately, we had to put her down during this anesthetic. But it just shows you how resilient cats are. So again, this is a quick diagnosis, and the owner was able to see this video and she understood then the reason why we needed to put her down. But whenever you're doing tracheoscopy in a cat where you're concerned about a laryngeal mass, you must always be ready for emergency intubation that is much smaller than you'd expect. So typically what I'll do is I'll take a urinary dog catheter and I'll detach the attachment to the smallest ET tube that you have and attach it to the end of the urinary catheter and then put it onto your oxygen. So at least that's a breathing apparatus that you can establish patency to the airway. And that's what we needed to do while we were calling the owner to advise euthanasia. Tracheoscopy, you can use it. I do find it's a little bit tricky with the 30-degree oblique, just because remember that your lumen is always going to be in the periphery of your monitor. So in order to get it central, what happens is that you're never going to really get it central unless you rotate your hand upside down or manipulate it like this. And when you're doing that, you're taking that tip and potentially putting it in through the trachea. So you can potentially perforate. So don't really use it all that often in a cat to get the good positions and the views that you need. So this is a bronchoscope that we're using. So it's a flexible bronchoscope. And as you can tell that there's that pixelated view, and the triangle up on the top of the images kind of gives you that, direction. So it usually should be in about the 12 o'clock position. That gives you an indication of the orientation of your endoscope position in relation to the area that you're looking at. So with the rigid, I don't tend to use it all that often in the trachea. And the limitation is that you can only get down to probably the level of the carina, but you can't get into the main stem bronchi or the bronchioles. So that is the limitation. Otoendoscopy. Now, after rhinoscopy, I would say otoendoscopy is the next one that I use the rigid endoscope most often in cats. And typically, they will have the same setup as you would for rhinoscopy. So as you can see, I've got it connected to continuous irrigation and also a 10 to 20 mil syringe on the egress port. And that just helps dilate the ear canal. So then basically it will help remove a lot of that waxy debris, and it will help illuminate and magnify the structures as well. So over on the right, that's a normal tympanic membrane of a cat. And that's the foot of the malleus that you can see, that long structure in the middle. And in the cat, that tends to be pretty straight. In the dog, it's more curved. But I think basically that's about it. But that's really the kind of clarity that you can get when you're using a rigid endoscope for endoscopy. So again, it can tell you whether or not the eardrum's intact, but also it acts as a therapeutic intervention because it helps remove a lot of the debris that can be lodged against the eardrum. So this cat, Zoe, had presented to me. She's a 9-year-old female neutral domestic short hair. And interestingly enough, probably about a couple weeks prior to presenting to me, she had a CT scan because she had dysphonia. And they found that there was a thyroid mass that had been removed. But as you can see from these images, the tympanic bulla looked pretty clear. Probably about 3 weeks later, she presented with upper respiratory signs. So she's pretty snotty and sneezy. And then about a week later, she started presenting with ataxia, head tilt, and circling. So she was referred to me for MRI because they thought that she had a brain tumor. But as you can see, she's pretty aware of her environment and she's not circling in preference to one direction or another, and she can write herself out of the circling, and she's very visual. She did have ansecoria, but again, that could have been due to that mass because again, that mass was pressing up against some structures. So we had a discussion and advised, listen, we can do an MRI because I can't exclude that this could be a central lesion that was missed on the CT. Or what we can do is otoendoscopy because it really looks like that this is probably a bilateral otitis media and interna. And if it's not, then, and if we don't find any pathology in the ears, then we can presume that this is a central brain lesion. And because finances were quite limited at this stage, the owner opted for otoendoscopy. And this is what her ears look like, both sides. And as you can see, the tympanic membrane's intact, but you can see this viscous material behind it with bubbles. So you can do a myringotomy and evacuate that material and send it off for cytology. And this is the material that was evacuated from both sides. And ended up it came back as mycoplasma infection, and it was likely due to an ascending infection from the acute onset upper respiratory disease that she had. So got her onto pradafloxacin and some steroids, and she did really well. This is her 45 minutes post-GA, and she recovered extremely well. And the vet actually had contacted the owner and said that the report was that she was slightly wobbly when she looked around, but in fact she was walking up and down stairs without any problems, and the owners were really happy. I saw her about 2 years beyond that, and she had a slight head tilt, but other than that she was doing really well, and I think to date she's still alive and well. This is another cat. And this is a case that I saw in Malaysia. Again, this household had quite a few cats that had chronic upper respiratory tract disease. And couldn't stand, couldn't move, and had chronic rhinitis, and I thought also bilateral otitis media and interna. So did a rhinoscopy, and as you can see over on the left-hand side, this is the nasal turbinates, and you can see that the turbinate tissue is completely retracted, and took biopsies of that, and there was a Pseudomonas osteomyelitis, so we got on the appropriate treatment for that. But as you can see, the tympanic membrane on both sides in the middle image shows we got significant disease. So again, did a myringotomy and had a concurrent mycoplasma infection. Got onto a marbofloxacin with some steroids and antivirals, and this cat here is now, this was 24 hours after the anesthetic, so you can see a massive difference just by that initial myringotomy relieving that pressure. So that's another quite successful case, but I'm finding that a lot of cases that are chronic upper respiratory tract cases can turn into an otoendoscopy case quite easily. Vaginoscopy and erythrocystoscopy, very rarely do I use the endoscope for this, but it is theoretically something you can do in female cats, erythrocystoscopy. Male cats, technically you can, but the endoscopes are so small and so fragile, and I'm not convinced that it's something that a general practitioner would be using on a routine basis. But you can get into the bladder quite easily and take your biopsies for culture and also for histopathology. The image over to the left is from Alison Berendt at the Animal Medical Center. They do a lot of interventional procedures and interventional endoscopy procedures in cats when they were putting in stents back in the day. And I would say that's probably the center that has the most experience in doing feline erythrocystoscopy. And I know they routinely use this mini MPR as well to help assist in these procedures. So I know that was a brief overview, but one rigid endoscope can explore at least four, actually 5 if you talk about vaginoscopy as well, 5 different body spaces. It is definitely value for money. I hope I've really illustrated the versatility of this endoscope and the fact that you can also use this in small dogs. Remember, I'm saying feline, but the small dogs can certainly benefit from the use of this endoscope. So I think it's definitely something that you will get a great return on investment. The one thing I would again reiterate is getting onto a wet lab course and understand how to use the endoscope in such small spaces, because it is more difficult working in smaller animals compared to your medium size. So practice on a medium, and then once you're comfortable with that, then you can graduate onto smaller and smaller animals. Thank you very much for your attention, and I'll leave it to Dave to get some questions.
Yeah, Elise, that was great. We do have a couple of questions, and one is, I assume this is when you're doing rhinoscopy, how do you ensuring that the patient doesn't aspirate a lot of fluid? Do you just pack the pharynx or what?
Yeah, that's a very good question. Oftentimes I don't pack the throat. What I'll do is I'll use the largest ET tube possible that's uncuffed. So that's the first thing. Then what I'll do is I'll use a chopped down needle cap, because you don't want to overextend the TMJ joint, because we know that that can lead to post-cortical blindness in cats. So it's very important to use a chopped down needle cap and relax the jaw. And then I tilt their head slightly down, so I allow the continuous irrigation to go up over the soft palate and then out of the mouth. If you pack the back of the throat, I find what happens is that absorbent material will absorb the fluid, and then that encourages the fluid to go down the sides of the ET tube and potentially aspiration. So again, largest ET tube that you can fit, unpacked. Now the caveat to that is that if you're worried about fungal granulomas, those are the times that I do pack the back of the throat, because you don't want the fungal plaques going down the airways.
Okay. Another question, do you routinely culture your nasal biopsies?
Yes, yes.
Okay.
Because most of the time they're coming to me because they're resistant to all treatments that the primary vet has given. So I think if it's one of those cases that they're resisting all the treatments that you're giving and you're going to go ahead and proceed with rhinoscopy, I take a biopsy of the actual nasal turbinate to send away, because I want to know what's going on in the bone, because that's likely the nidus infection, not just the superficial purulent material.
Another question is, what are the etiologies of the nasopharyngeal stenosis?
I don't know if that's been specifically established. We know in cats, it tends to be more chronic rhinosinusitis that may very well encourage the nasopharyngeal stenosis to form. I have seen chronic foreign bodies where I pulled out a grass blade. I wish I would have put that in this presentation, but a grass blade that had been there for, I think, over a year, and it created, there was a nasopharyngeal stenosis, so the grass actually couldn't escape because it was blocked in. Also, after a dental, someone put a dental drill up into the socket of, I think it's either 104 or 204, and knocked the tip into the nasal cavity, and then had a chronic rhinitis, and took some nasal x-rays and did retroflex nasopharyngoscopy and found that there's a nasopharyngeal stenosis, and this tooth was going back and forth between the tip of the nose and the back of the nasopharynx because it couldn't get out. So yeah, so those are probably the two things that I think probably likely predisposed to nasopharyngeal stenosis. Again, we read that aspiration during an anesthetic can cause that. I've not seen that in cats. It seems to be more of a dog thing, but because I'm quite cat-centric, maybe I'm biased, but that's probably something that Dr. Tweed can report.
Yeah. And then relating to the stenosis, after you laser it, would you consider using a balloon opening and then implementing some sort of stent to maintain it open?
Yeah, some people have used stents. So the Animal Medical Center I know in New York is really big on stents, and I think they've trialed a variety of different ones. My experience with them is that you do need to have fluoroscopy to really get the adequate placement. Because if it's too far rostrally or caudal, it can cause some problems. In my experience, and I think in their experience as well, is that they respond really well to balloon dilatation on its own. So I think a stent would probably be the last resort. It can be quite an elegant way of addressing the problem, but not necessarily needed. So I would say unless you had a series of failed balloon attempts, then probably not. Then you could probably look at doing a stent.
Okay. Do you have any idea what may account for the higher prevalence of otoendoscopy outside the UK in your practice?
I've always wondered this. I was thinking about this today. I had a feeling this question was going to come up, in fact. I don't know if it's because in the UK, we've got people who are more keen to get their animals in at the first indication that there could be a problem with the cat. So at one sneeze, usually the owners will bring the cat in, where maybe in some other socioeconomic backgrounds in the UK and outside the UK and also in different countries, perhaps that's not something that that is feasible. So, and also there's a lot of street cats. So in Asia, for instance, I see a lot of street cats coming in and they've got the chronic rhinosinusitis, and oftentimes they are rescues from the streets. So an owner will rescue them and introduce them into the household, and then everybody gets sick. And then you've got a whole colony of cats that have upper respiratory disease. And then gradually it will progress into probably an ENT problem. So I don't know. I do wonder if maybe if climate also encourages it. So there's a variety of different factors that could maybe explain why we're seeing a higher incidence in some of the more tropical areas compared to the UK.
Okay, we got time for maybe one or two more questions. In doing tracheoscopy, do you prefer to go through the endotracheal tube or parallel to it, or not use one at all?
Right, so that's a good question. In cats, you can't really go through the ET tube. So usually an ET tube is about 4.5, 5 if you're lucky in some cats. The smaller the size of the bronchoscope that you've got, obviously the image quality is going to decrease, and also they're more expensive the smaller you go. But putting that through the lumen of the ET tube, what's going to happen is you're going to completely obstruct the airway because you've got very little room between the endoscope and the ET tube itself. So you're going to obstruct the airway. So oftentimes we'll remove the ET tube and use intermittent intravenous anesthetic to keep them under. You can use a dog catheter alongside the endoscope if you wanted to provide oxygen, but oftentimes tracheoscopy is literally, I'd say, a 10-second procedure if you're quick. But really going through the ET tube is not something we typically will do.
Okay. One final question. Do you ever check hemostasis before doing your nasal biopsies?
If the animal is an older animal, has evidence of bilateral epistaxis, so if it's an older animal, I'll do a blood pressure, and I'll also do coags and potentially a buccal mucosal bleeding time as well. I usually, just on the safe side, always recommend that for all animals that are older. Those younger animals that are presenting with epistaxis, I will certainly advise that as well. But it's not necessarily all routine, because some animals will have a grass blade in the nose and have nasal bleeding, so that doesn't really indicate that you need to go in with coags all the time. So I think it's really a case-by-case assessment.
Okay. Well, I think that's it, Elise. I want to thank you very much for a fantastic presentation.
Great.
Also, to remind people that Elise will be coming to Colorado State University Translational Medicine Institute teaching a feline endoscopy course, so you can certainly learn more and do hands-on endoscopy. Just to remind you that next week we'll be hearing from Dr. Mike Lieb. Dr. Lieb was on the faculty at Virginia Tech and taught gastroenterology and GI endoscopy for many, many years. Dr. Lieb will lecture on endoscopy of the stomach of dogs and cats, highlighting what you can diagnose. That's next Wednesday, October 14th, 8 p.m. Eastern Time. That's New York time. And also remember that you can listen to Dr. Robertson's presentation as well as previous presentations on endoscopytalks.com. That's completely free to anyone that wants to listen to previous presentations. So we're wishing you all the best in your practice, and of course, best health during these challenging times. And we will be looking forward to seeing you next week with Dr. Lieb. Thank you very much.